This is Kunal Lal for Digital Dentistry Forum. Today I would like to share with you my technique for intraoral imaging using a new patent pending device. Before we can improve on a technique, we have to identify the shortcomings. And I'm sure many of you involved with intraoral imaging can relate to some of these shortcomings that I identified. Fogging of the lens was a significant challenge, and patients tend to breathe, and especially for mouth breathers, this was always a challenge. Saliva is always present in the mouth, and if it gets on the lens, it can distort the images acquired, even though we try and isolate as best as we can using various devices. We frequently have to remove the intraoral imaging device out of the oral cavity and wipe the lens before we can resume acquisition. Distorted acquisition of overlapping data will result in improper stitching of the 3D model. The software does a relatively good job of cleaning up the multiple data sets, but it takes longer to process the data and it can still result in errors. We try and juice up our computers with more processors and more RAM, where the emphasis should really be on fast, easy, and accurate data acquisition. It can take up to 3 minutes for the computer to process a complete maxillary and mandibular arch scan. Imaging of the mandibular arch can be even more challenging due to the presence of the tongue and pooling of the saliva and difficulty in retraction. This is an example where an entire maxillary arch was scanned in about 34 seconds, and it was a rapid, easy, and accurate data acquisition without a drop in continuity. And you can see there's very little to no overlap in the data set. It did spend up to an additional minute to fill in some missing holes in the acquisition. I routinely do full arch scans, and I found this technique to result in the most accurate articulation, in many cases better than the CEREC Ortho software. The occlusion was definitely not 100%, but it was pretty close. This is a patent pending device that I developed to be attached onto any intraoral imaging camera, and it provides a continuous stream of warm air that prevents fogging and removes any saliva or debris that obstructs the imaging. So this is acquisition of the same patient on the maxillary arch using the device, and you can see the difference and the ease in acquisition. We are currently still beta testing the device. Any clinician interested in being part of the beta testing group should contact me directly at my email noted at the end of this presentation. Thank you.